Good afternoon, everyone. So, today's topic is periapical radiopacities. So, how do you classify periapical radiopacities? You have true radiopacities, anatomic radiopacities, and false periapical radiopacities. So, coming to anatomic radiopacities, it is again classified as what you see in mandible and what you see in maxilla. Coming to mandible, we have the mental ridge, Jeena tubercles, external oblique ridge, internal oblique ridge, inferior border of mandible. And coming to maxilla, we have anterior nasal spine, floor of the nasal cavity, nasal septum, floor of maxillary antrum, zygoma, maxillary tuberosity, and coronoid process. So these are some of the pictures that you see where you see the radio opacities. Here you can see the floor of the nasal cavity, the zygomatic process, and floor of the maxillary sinus. This is a Y line of NS that is formed by the lateral wall of the nasal fossa with the medial wall of the maxillary sinus. So this comes to an inverted Y, and this is the floor of the maxillary sinus, which is a radio-opaque line. You can see this in this radiograph. External oblique ridge, Jeena tubercles, mental ridge, that is a V-shaped radiopacity that is seen in the mandibular anterior region, and inferior border of mandible, that is a thick radiopacity that is seen at the apex of the molar teeth. So coming to, that was anatomic periapical radiopacities. Now coming to two periapical radiopacities, we have condensing osteitis, periapical idiopathic osteosclerosis, periapical or focal cementoceous dysplasia, unerupted succedaneous teeth, foreign bodies, and hypercementosis. And coming to rarities, we have calcifying odontogenic cyst, ossifying fibroma. Coming to condensing or sclerosing osteitis, what is sclerosing osteitis? Osteitis, that is a sclerosis of bone that is induced by inflammation or infection. That is a sequelae of pulpoperiapical infections, and it is associated with a non-vital tooth which is painless and asymptomatic with no cortical expansion, and that regress after the treatment of the infected tooth. So radiographically, you can see a periapical radioopacity that is seen at the apex of the pulpally involved tooth. Now coming to periapical idiopathic osteosclerosis, that is also called as anostosis, bone whorls or bone evacuation. It is mostly idiopathic, the cause is not known, and commonly seen around the periapex of first premolar and canine region. The associated tooth is vital, and radiographically you can see the radio-opacity with irregular border. So what the difference between condensing osteitis and osteosclerosis? Condensing osteitis is a sequelae of pulpoperiapical infection where the tooth is non-vital, whereas in osteosclerosis the associated tooth is vital. The next lesion is mature periapical cemento-osseous dysplasia or focal cemento-osseous dysplasia, which is commonly seen in mandible, and it has got a female predilection. It is mostly asymptomatic except in cases where expansion of the cortex is noted. And this is also associated with the vital tooth. Radiographically, we can see a round or oval smooth contoured opacities and dense and devoid of trabecular pattern. So these are the radiographic appearances of cemento-osseous dysplasia. Coming to hypercementosis, which is also a common lesion that is seen radiographically, it is also called as cemental hyperplasia. There is excessive formation of cementum on the surface of the root of these teeth, and asymptomatic, it is asymptomatic, which is associated with a vital tooth. You can see the bulky root that is seen at the apex of the premolars of the maxillary in this radiograph. Coming to mature cementoblastoma, it is an odontogenic neoplasm of cementoblast, and 75% arise in the mandible with 90% arising in the molar and premolar region. There is no significant sex predilection, and it is predominantly seen in children and young adults. Pain and swelling are present in approximately two-thirds of the patients. Radiographically, what is seen is it appears as a radio-opaque mass that is fused to one or more tooth roots, and that is surrounded by a thin radiolucent rim which is suggestive of a capsule that is present. The outline of the roots of the involved tooth is usually obscured as a result of root resorption and the fusion of the tumor with the tooth. Now coming to false periapical radiopacities, we have impacted teeth, supernumerary teeth, compound odontomas, tori, exostosis, peripheral osteomas, retained root tips, ectopic calcifications may be sialoliths, that is a salivary stone, rhinoliths and antoliths that is present in the nasal cavity, calcified lymph nodes, and phleboliths that is present in the blood vessels or veins. So the false periapical opacities have a characteristic feature that is diagnostically useful. That is, their relationship to the apex is such that the image can be shifted from the apex by the tube shift technique. That is how you differentiate between a false periapical radiopacity and a true periapical radiopacity. For example, impacted teeth and supernumerary teeth. Now coming to compound odontoma, these are the radiographic picture. It is radiographically, it is radio opaque, which is having a similar density that of enamel and dentin. The ectopic calcifications, that is a calcified lymph node that you see here, and the silolith, which is present in the submandibular salivary gland, which is the most common one that is present, mainly seen in occlusal radiographs as a calcified or radio-opaque mass that is present. So that ends with the topic, and the content is that you should be able to differentiate between a anatomic radiopacity and a true periapical radiopacity and false periapical radiopacity, so that for a true periapical radiopacity a proper treatment has to be done, whereas a normal anatomic landmark and a false radiopacity should be differentiated from a true one. So that is the end of the session. Thank you. Thank you.